as a thought exercise, thinking about if I'm here and I'm talking to you and we're on this podcast, and the first thing I say when I come on is like, Jessica, you're not an author. You don't have a successful podcast or any combination of things that you do or that kind of informs your day-to-day life. Like, of course I do. That this is my life. This is who I am. Imagine you go around the rest of your day and people are giving you reproachful glances every time, at the very least, when they're talking about these basic core things that you value in your life, and that's repetitive and constant throughout your holistic experience in the world.
Welcome back to Making It Awkward. I'm your host, dietitian and author, Jessica Wilson. You can find me on Instagram at jessicawilson.msrg, and you can buy my book, It's Always Been Ours, wherever books are sold. This is an independent podcast, and you can support the show by rating, reviewing, subscribing, and joining the Patreon when you leave an Apple Podcast review or Spotify comment. I bring my dad back to the show to read them.
This one says, this is a fun podcast to listen to. I'm so impressed by Jessica's ability to listen to some wild cases. If you're going to listen, make sure you give it more than a normal 5 to 7 seconds, which I'm surprised people don't do. And of your attention. Half the episodes are satire, and you might think she's on the opposite side of where she is, but she's not. Very unique podcast that is fun to listen to, but also gives me great information. Jessica has lived experiences in the area of food, nutrition for real people who are struggling, and in her conversations with out-of-touch scientists, policymakers, etc., she knows how to bring it back to real people who are directly affected by what these experts, quote, are preaching.
This person gets it. Finnegan didn't get it.
Yeah, he must have did his 5 to 7 seconds.
All right, today's episode is an additional follow-up to my conversation with Dr. Carol Lieberman, a forensic psychiatrist for whom Reagan had just one flaw.
The big problem, there are two main problems in psychiatry.
Okay.
One is that we closed the state mental hospitals.
All right.
And threw all the patients out, with the saying being that we are giving them the least restrictive environment. So it was supposed to be a good thing. But in fact, with people who were in the state mental hospitals, most of them had schizophrenia or manic depressive illness, bipolar disorder, or addiction, chronic addiction, things where they did need to be in the hospital for a very long time. You can't solve these things overnight. And in fact, schizophrenia, you can't cure, or bipolar, you can't cure, but you can treat them and control the symptoms. But you also need to give them insight into their disorder. And so, because you can't just let them out into society and hope. I mean, the idea was that they would go to clinics, that there would be these community clinics that then these patients were supposed to go to. Well, once they ran out of their meds, assuming that they kept taking it every day to begin with, which was not really likely, but because in the hospital they are given the meds every day,
Right. Yeah.
So even if they took their meds, when they ran out, I mean, the idea that they would be able to find their way to a community clinic, and there weren't enough community clinics built at that time anyway, and there still aren't enough, that was a ridiculous, anybody who knew anything about these things. So anybody who knew anything like that, could have told the president. It was Reagan. I love Reagan. Everybody loves Reagan. Well, not everybody, but he was a great president, but he got wrong advice.
All right. Yeah.
He was getting the wrong advice.
Okay.
So it was doomed from the get-go.
Dr. Carroll's comments on mental health warranted a full episode follow-up, and thankfully Kyle Davis, a social worker in Minneapolis, Minnesota, was able to join us. He has extensive experience working with people who have severe and persistent mental illness, or SPMI, in an assertive community treatment model. He shares details of that model today and what autonomy can actually look like for folks with mental health challenges. Kyle shares his thoughts on the idea that people develop insight while living in institutions, and how a multidisciplinary approach proves that people heal best in their communities and is more beneficial long-term than having more community clinics, as Dr. Carroll proposed. Kyle shares the presentations of mental health conditions that people live with, including schizophrenia, schizoaffective disorder, and bipolar disorder. And he refers to the positive and negative symptoms. We can think of positive symptoms as those that are added to what we would stereotypically think of as a healthy brain brain, or easily observable as something beyond what we're used to seeing in human behavior. So hallucinations, bizarre or disjointed sentences, tangents in speech, expressing grandiose ideas about oneself or the world, or paranoia about the world far outside what would make sense to most people. The negative symptoms are more subtle and could look like what we would associate with autism, depression, anhedonia, or even just personality traits a lot of people have. And these would make it difficult to quickly observe if someone lives with schizophrenia. Negative symptoms are the ones that typically occur leading up to a quote break, typically associated with the illness, and are often what persist even when positive symptoms are managed. And an incredibly fun note is that Kyle is married to regular podcast contributor and Casey Mean scholar, Selena Salfin. And with that, Kyle, welcome to the show.
Thanks. I'm very honored to be here, Jessica.
I'm super grateful for your time. Can you introduce yourself to listeners?
Yeah, my name's Kyle Davis. I am a licensed independent clinical social worker. I'm a current mental health supervisor. I work in kind of a hybrid safety and justice mental health job right now where I supervise embedded social workers trying to collaborate to reduce police interaction in 911 calls. But prior to that, I worked as a therapist on an assertive community treatment team for about 12 years. And that's kind of where my passion lies in terms of community mental health and service.
Mm-hmm. You abbreviated that as ACT. So can you say the phrase again?
Yeah, absolutely. ACT is assertive community treatment.
Okay.
It's an intensive multidisciplinary case management model that's been around for quite some time in different permutations. It strives to be a hospital without walls, in a sense, and kind of operates a little differently than that. You have psychiatry. It's one of the only models, I think, if not the only one, where psychiatry will go into a client's home. You have a therapist. That was my role. You have generalist practitioners, peer support, vocational support, and substance abuse kind of co-occurring treatment.
Nice. And you said you did that for how many years?
About 12 years.
Okay. How did you get into that line of support?
Kind of stumbled into it. I finished my graduate program in New York City, and I had worked for an agency back home, kind of starting out in adult foster care, which is where a lot of people start out with in the field, and was able to get a job with very minimal idea of what I was going to be doing. And then was very fortunate to find a career that kind of completely aligned with my values. Yeah. ACT has sort of kind of the opposite of even what you would see in the hospital or in traditional settings. It's very non-hierarchical structure. In a sense, there isn't sort of a top-down modality to it. Everybody in the room who's discussing client care, and we have something every day in the morning that's somewhat similar to rounds that you'd have in a hospital, where we discuss all 80 to 90 clients on the team. And we all have a set schedule, but we're reviewing the situation every day and talking about where the needs are in the community and where the needs are with each individual client, and modifying our approach if necessary, and usually on a day-to-day basis. And the whole idea about ACT and how the fidelity model has to work is that the person who knows the client the most and sees the client the most frequently becomes kind of the expert, has the best rapport. So if a peer support specialist has seen someone every day and sees a lot of things like this person's struggling in this area, I see some breakthrough symptoms, even my thoughts on how they're looking after a new medication has been tried. If the psychiatrist or the prescriber hasn't seen them in a month or so, you would defer to the person with kind of the keeper of the knowledge. And then it kind of generates this robust conversation. So no one is kind of making these really tough ethical decisions on a day-to-day basis in isolation, or kind of making them from, again, kind of this authoritarian piece. So I feel like it's the closest we can get to kind of that model of care that's truly holistic and respects clients' autonomy and rights. And again, the conversations get very heated day to day too. People understandably have different perspectives on like how far we're going in certain areas, what clients deserve more resources than others. Where is our implicit bias falling in terms of how we treat folks?
Wow. What types of diagnoses would you see in that setting?
We would see primarily the model is designed to serve clients with schizophrenia, schizoaffective disorder, bipolar disorder.
Okay.
And the one criticism that I can actually attest to that comes up a lot is that it is somewhat of a restrictive model because it's a rehab model in a sense. It requires folks to have buy-in in terms of their treatment, which is always kind of a murky ground to walk through with folks. So one example is that it might not be a great fit for a client to work with us if they're just 3-4 months just aren't coming to the door and have no interest in treatment. So in that sense, it doesn't especially matter if you go out 5, 6, 7 days a week, which we can do in ACT versus like once or twice a month in a traditional case management model. It doesn't really matter if someone's not really working or doesn't want to work with that. And that's understandable. And sometimes we give a lot more time for folks to kind of see if they want that service or if it can be helpful to them. But I think people kind of lament that, okay, you have this comprehensive care team and this client I'm referring is having a really hard time and they're too challenging for just one person to work with them. So we'll get 12 people to work with them and then kind of find that the results can be the same if there isn't kind of client buy-in and client choice.
Can you run through symptom presentation for folks with schizophrenia and schizoaffective disorder?
Yeah. I think often the way I like to address this is to think about how much language matters and how much I think that still impacts the popular perception of these illnesses and persistent mental illness in general. When you look at the name schizophrenia, it literally means brain split or brain schism. That's what it translates to. And I think when you take that and you think about talking to somebody about this, some of the language they use is that they're kind of fundamentally a different person. They've changed into someone else. There's a duality. There's a shadow self. There's someone who does, it's kind of a Jekyll and Hyde conception of that. And again, it's in this sort of ancient name. Bipolar has kind of that same dichotomy where people will say this person was really moody one minute and the next minute they snapped. And that's not how the illness works. But I think, again, it's kind of that duality, that doubling, that polarization of the illness. I could go on and on. I think, borderline personality, which is another feature. I mean, this was made by men who were commiserating about women.
Yeah.
They deemed borderline impossible to treat at the time. So what effect does that have on folks and their conception of what healing is or what help they can get, even if that's what the language is? I think that what's so ironic about those conceptions is that the vast, vast majority of the time, schizophrenia and these accompanying disorders, the concerns you have with folks are ones of avolition, like a struggle, kind of self-starting, response latency, kind of a real struggle to kind of engage in those day-to-day kind of intentional tasks. So I often say, I think people think about these illnesses not in that kind of disorganized context, but in these ways where this person could hurt me or harm me, or even I don't know what they're going to do kind of thing.
Sure.
But the tendency for disorganization in the mind that comes from these illnesses, there's so much preoccupation, so much going on that the largest struggle is, and again, this is why there's brief, frequent interventions, is that folks might struggle so much with internal stimuli that it might be up to and including they'll sit in a chair, chain smoking throughout the entire day and completely lose track of time and struggle to kind of meet those just basic criteria of those activities of daily living, we call them. So there's two categories of schizophrenia. There's the positive symptoms and the negative symptoms. The positive are disorganized speech and behavior, hallucinations, which can be auditory, visual, or tactile. So all these ways they can feel that internal pain, social withdrawal, and kind of that cadence. There's a cadence of speech that's kind of hard to describe that sometimes happens where people will experience a lot of fearfulness. Paranoia would be the clinical term. I'm trying to be more client-centered in that, but just really be fearful of multiple things in the community and kind of just list off those things unfettered for about 5 minutes. And then it almost needs kind of a verbal injection to kind of stop that process. The thing is with negative symptoms, those can come even when somebody is optimally on medications that are actually working to alleviate a lot of those positive symptoms. And I think people forget about that a lot. And that can be just flat affect. Again, that response latency, lower mood, difficulty concentrating, things like that. So really all these things that are not optimal for kind of navigating the neurotypical world, especially like think of a job interview. If you get asked a question and it might take 15 seconds to answer that question, people are really uncomfortable with that. And if that question gets asked and you're just kind of staring back at the person during that time because you're just trying to organize your thoughts and get everything together, that can really kind of be a barrier. Not only going to the doctor, but contextualizing everything that's said, advocating for oneself when you're at the doctor. Those are two things that I find consistently very challenging. Reading for a long period of time. I've had a lot of clients talk about how they just can't just read a book like they used to. So that's kind of the overall misconception of the illness, is just that, again, if I had to summarize it, it's a disease of avolition most often.
Okay.
Yeah.
Is schizophrenia, bipolar disorder, schizoaffective disorder, I assume it's on a spectrum. So, I could see somebody and work with somebody and, not know that they had schizophrenia. Is that true?
Absolutely. A resounding yes. I think we have this popular conception that people with schizophrenia are talking to themselves, that while they're living with that they're constantly responding to internal stimuli. It's not always a visual component. And most often what I've encountered, even with folks that are frequently hospitalized for it, which is kind of a tiny subset of that 1% of the global population, you wouldn't know it. You might have some preconceived notions reading their medical history or going into these situations, but largely it's subtle. There's details that you'll see from day to day that are not kind of the more traditional examples that I mentioned of positive symptoms. Mostly you're living with some of those negative symptoms, kind of those struggles with self-care, kind of those struggles with communication, kind of the volleying back and forth in a conversation or finding your words, things like that, things that are more frustrating for the individual and not as apparent to the outside observer.
Okay. Bipolar disorder, I feel more so than schizophrenia, something that as a culture we have integrated and is a much less stigmatized diagnosis. I wouldn't assume, because of that destigmatization, that folks would be served within that ACT model. But again, is that the spectrum portion of it?
Yes, it is. And I feel like it especially comes down to there being sort of a thought component to the experience of mania that folks often have. That's what can lead to hospitalizations. When people have episodes where their energy increases a lot, you can have a lot of this expression of symptoms of, for example, grandiosity, feeling like they have to get a lot of things done right away. It's almost like when you think about all these things, when you do some self-analysis and you think about why someone would want to be in that frame of mind, often I get this kind of stated to me pretty plainly. It's like, I've felt really low for a long time, and then I wake up and I have this incredible burst of energy and creativity, and I'm not taking a pill. I'm not using a drug to initiate it oftentimes. Who are you to tell me that I shouldn't feel this good all the time? And often how good they feel during those periods of time, it's really hard to kind of touch base with them and kind of reset around what kind of things are happening in their day-to-day life that are things that they wouldn't want to do if they weren't experiencing that. It becomes kind of like that acknowledgement of that discrepancy kind of thinking. So that's the real challenge. And I feel like I've worked with a lot of folks where I've tried to advocate for them and let them kind of exist in this mode where I know that someday my mania is going to resume, and I'm welcoming that. And I feel like I'm a healer. I have extra sensory abilities, and that I'm truly myself when I'm in that mode. And we allow that. We allow for that. We don't mandate medications or anything like that. We don't make it an absolute deal breaker for whether somebody can stay within having our services. We can point out patterns. We can talk about what's happened in the past and just make sure the person's okay with that expectation. And sometimes we just disagree on what that might look like.
Sure.
Yeah.
So still in the ACT model, there's the autonomy and ability to seek or refuse care.
Absolutely. There's that whole person-centered treatment planning process where we really do collaborate with clients to make their goals. I've always kind of overthought that in a way, you might say. Like, I think that, we have to kind of generate these treatment plans that allow people to have goals for reimbursement, for MA reimbursement. And I often ask myself, like, what are my goals for the next 6 months? Like, what am I going to try to accomplish? And sometimes those aren't conventional things and aren't things that can be easily measurable. We always want numbers. You're going to learn 2 new skills. You're going to go to 3 different places. You're going to try things. And these are a great rubric, but really, again, kind of referring back to the work being really complex, being really ethics driven, not being one size fits all, and having that flexibility within the program to do whatever it takes to reduce cycles of hospitalization and ultimately custodial care in general is kind of what the model thrives on.
Interesting. So let's go back to my conversation with Dr. Carroll and her ideas of autonomy, especially in the I don't have to take a vaccine or put things in my body if I don't want to. But what we should not have done is let people make decisions about their own care. So what do you think about the historical rhetoric about Reagan letting people with mental illness onto the streets, and that inherently was a bad decision for society? What did that bring up for you?
Yeah, I have so many thoughts. I can So one of the ideas about where I think this all begins in a lot of ways. So post World War II, a lot of these ideas we have now kind of about a utopian society, the greatest society kind of things come around. I mean, in the 1950s, and I think ironically, given the current rhetoric, a lot of those thoughts started with veterans of World War II who were in this custodial care model, and there was some evidence even at that time that people who were treated in their communities, with their families, with their support systems, had much better outcomes than that they did at the time. So going through the 50s into the 60s, that push to try to get folks out of custodial care was there. And I think it touches on so many different nonpartisan issues, but I think ironically, it also hits a lot of points that the right would like to see, because conservatives with schizophrenia and severe and persistent mental illness, or SPMI, they vote and they want liberty, autonomy, free speech, the ability to exist in a space and act quote unquote weird or strange or make people uncomfortable if they see them, and not be put away for their entire lives, which is what was happening at the time. So with that in mind, that seems kind of like a no-brainer. They wanted to kind of implement that model a little more, and that as they started to plan that, the idea was that these mental health clinics would get formed. They would put 2,000 of them across the US, and then this would solve the problem. Or states would decide how to kind of create the connective tissue to bring those entities together to help people after discharge from these hospitals access care in the communities. And first of all, they got to, I think, 754. And none of that infrastructure was really codified or built within those systems. So when people were discharged, you see that kind of lack of care. You see that what Dr. Carroll was mentioning, that people aren't getting to these clinics and taking their meds. Mm-hmm. So really what became the next step in that model is that social workers and clinicians started to kind of almost go rogue in a way. There's all these anecdotal examples of people in the state hospital system seeing, okay, when we send these clients back out in the community and we don't see them for a while, certain providers see that their clients aren't coming back as much as others. And then you would have individual clinicians just kind of going back to their homes after they were discharged, driving them around, getting groceries, getting a feel for their home, getting a feel for what they need, seeing if they can cook their own food, just seeing if they could pay their rent, things like that. And then lo and behold, when they're able to kind of have that minimal, again, infrastructure in their homes to feel comfortable, to feel safe, it reduced those cycles of hospitalization. Same with the mental health clinics. If people were able to kind of bridge that gap between community care and the mental health clinics, people had much better outcomes. So then the Evidence-Based Model Act that I'm in kind of came as a result of trying to do that, again, as a whatever it takes model, that you could see somebody every day, multiple times a day if you need to, and that they're brief, frequent interventions versus longer, infrequent interventions in people's homes. So they get gradually more and more comfortable with living independently.
Okay.
Yeah.
So out of an institution and into society.
Yeah.
Yes.
Absolutely. Yeah.
Dr. Carroll was also mentioning that the only way for people to gain insight into their condition was to be locked away 24 hours a day. And I was wondering what that brought up for you.
Oh, it actually made me laugh quite a bit because I was just thinking about all the clients I've worked with over my career and trying to think if I could think of one that didn't fight so hard with every bit of themselves to stay out of that kind of custodial care, to limit an acute hospitalization. People do not like to be in those situations. And I guess just the overall question too, I would ask is what her experience would be seeing people build insight, that nebulous idea of it in a controlled setting like that. Folks with severe and persistent mental illness, there's this broad estimate that 50 to 98% of them struggle with anosognosia, which is a lack of insight into the fact that they have the illness to begin with. So as a thought exercise that I still have to remind myself all the time, and I work with my staff on, and we talk about a lot, is when people are experiencing these symptoms and they seem like there's no way this person can really believe these things because they seem to somebody not experiencing them as possibly outlandish or grandiose or things like that. And I just, again, as a thought exercise, thinking about if I'm here and I'm talking to you and we're on this podcast and the first thing I say when I come on is like, Jessica, you're not an author, you don't have a successful podcast or any combination of things that you do or that kind of informs your day-to-day life. Like, of course I do. That this is my life. This is who I am. Imagine you go around the rest of your day and people are giving you reproachful glances every time, at the very least, when they're talking about these basic core things that you value in your life, and that's repetitive and constant throughout your holistic experience in the world. If people aren't willing, understandably, to give up the things that are most vital to their existence, their livelihood, their personality, their core beliefs in themselves, and challenged all day, every day, you're not just going to snap out of it or whatever. And even optimally on medications, in a lot of cases, some of those core beliefs persist. And I guess ultimately the question is, why would somebody in a controlled setting around other people who are struggling with the same perceptions gain that insight in that limited milieu? Why wouldn't you gain that insight or have a better chance of doing it, having a broader range of experiences out in the world? Or if you maintain those core beliefs, that can be okay, and that you have a larger variety and more infrastructure, again, to think about how you're interacting with the world and interacting with other people. It just gives you more opportunity, and it's what folks want. So, those are my initial thoughts.
You mentioned the medication piece. And again, Dr. Carroll was convinced that people, won't continue taking their medication. Curious about your thoughts on meds. And then beforehand, you were telling me about injectables. And I think that'd be super interesting for people to hear about.
Yeah, definitely. I think to Dr. Carroll's point, I was thinking a lot about, even in the 12 years I've been in this career, there was a time when oral medications were kind of more of the gold standard. And a lot of our job on our team would be the last several hours of the night before people went to bed. We would just drive around the county prompting folks to take their meds. And if people didn't come to the door, or if they decided that they didn't want to take them in the moment, that could be ultimately problematic. But eventually, with those, again, brief, frequent interventions, people were more likely to stay on them long term. But since then, there's been a lot of developments in long-acting injections where you can get the same medications people would take orally injected once a month, once every 3 months, even once every 6 months. And if people are willing to have that buy-in, it can help with that idea that you can be more autonomous in the community. We can leave you alone. We can help you live your life. You can have more choice. Again, we don't have to see you as much. So I feel like that kind of glosses over that idea that although community mental health clinics are wonderful, I've worked at one, people struggle with access. There's so many barriers to kind of get out there and really prioritizing that part of your care. And if we can both go to people to initiate some of that idea of developing autonomy and provide that medication in a clinical setting or in the community. The nurses on our ACT team would talk endlessly about all the places they've given injections for folks, like in parking lots, in their car, in clients' houses and apartments. And that flexibility really helps people kind of get to that next step where ideally hospitalization is just something that they don't have to experience anymore.
So with folks on those injectable or long-term medications, do symptoms, quote, go away, or what's different or what's helpful about them?
It's always a tough question because this goes by clients' self-report. So if somebody is experiencing an alleviation of some of those positive symptoms we're talking about not having hallucinations, not hearing voices, and they don't acknowledge that those were not real to begin with. Once they're not as observable and it doesn't seem like there's as much reaction to it, you can still have that feature where they're like, well, yeah, I'm fine. I'm okay. I was fine before. But I think the collateral of that is that all the medications that folks take, all neuroleptics, have some kind of side effect that people are trying to get away from. It's usually sedation, sexual side effects, just a lot of reporting you don't feel like yourself. I've had people report that they just don't even feel like their sleep is real sleep anymore, even without sedating aspects. And just a lot more difficulty doing the things that they like to do before. So there's this kind of trade-off. So I almost feel like in some cases when the medication is optimized, the person exhibits more of those negative symptoms, like more depression, more kind of like, is this life now? So it's always a trade-off. It's not like these things just completely make life wonderful for folks.
Yeah. Okay. So societal question. I've heard the terms, even in, progressive circles, of like when or when not to call the cops if I'm seeing somebody experience, quote, a mental health crisis, right? Which could just be somebody, talking, it seems, to themselves or whomever they think they're talking to. Personally, for me, that does not signal a mental health crisis, or like for sure nothing that I would call the police about So can you confirm like that? Yeah, that is just something that is happening. That can you talk about people's concern about violence, when someone is talking to themselves?
I think the big struggle there is that if somebody is walking around, for example, in the street, waving even a knife or something like that, and we know even when we're working with them that this person's never harmed anybody or done anything.
Sure.
If you're in sort of a very social milieu and things like that happen, you can get a quick 911 call and there might be a police response. I think that we like to go case by case in mental health and try to think, could this be a collaborative response? Could we get a crisis team to go out and kind of act as kind of a buffer in that situation? You also get, I think what you're referring to more is a lot of calls like, I'm looking over at my neighbor's house and they're talking to themselves in their backyard.
Right.
No, police should not go out for that. It's not illegal for someone to talk to themselves in their backyard. And I think what people really, and even in my field, what people sometimes struggle with is the idea is that if this person is struggling and I take them to the hospital and they say they don't want to be there, they'll probably get discharged within a couple hours, unless their symptoms are so severe or there's a really protracted history of self-neglect, which is way more often when people are involved in acute hospitalizations. Once they get discharged, you have to ask the question is, if I have a relationship with that client, are they going to want to talk to me the next day if I initiated an involuntary hospitalization against their will? So I like to always say in our work, we spend 90% of the time being the least restrictive option. We want people to live as freely as possible. And then sometimes if we've known somebody in ACT for 5, 6, 7 years, longer history where you're seeing somebody much more than you're even seeing some of your family members in some cases. You know them and you know their patterns and you're trying to create a narrative. You're saying if there have been 7 examples of this person becoming so inundated with internal stimuli that they want to jump off their balcony.
Sure.
Or they go on a bus and just punch the bus driver in that setting.
Sure.
You want to try to intervene and create that narrative just to keep everybody safe, especially the client, because the client is much more likely to be harmed in the community.
Yeah.
But, yeah.
So it seems like there's a huge difference between someone who is going to be violent versus the person on my street corner who just seems to be chatting with himself.
And I think that conflation with being unhoused and being mentally ill and how that impulse to revert back to those old ways of thinking, like this person needs to be put in a care setting against their will for the rest of their lives. There's a lot in between those two extremes, as we've already discussed.
Yeah. And I'm not sure why it's taking me so long here, but of course, this is bringing up all the eugenics of it all, both for homeless, unhoused folks and for folks with mental illness. How Americans just want to pretend like everything's fine, but also like wanting the white race to be hygienic is always one of my favorite words here historically. And now do you still see the preference for a stronger white race to be a through line for all of this?
Well, definitely. I also think that what this makes me think about is that the demographics of mental health aren't restricted to one race. So there's so much that happens out in the community where, kind of like I said at the top, where if somebody is really struggling, like who makes the determination if someone's individual rights are taken away? I mean, I've referred to it being more ideally kind of democratic and committee-based, non-hierarchical, but what is it? Is it a judge? Is it a mental health professional? Who decides when and how you take away someone's individual rights? I see it coming up a lot more the way it bothers me every time I hear it, where there's a mass shooting and people's like, well, we just need better mental health. And there's been so many wonderful editorials written about how our systems actually work. Like trying to imagine if somebody is just saying they have an intention to do something, but they don't really have a means or a plan. These folks can voluntarily not receive treatment, and you can't really do anything based on like a thought or an idea. So I feel like any impulse we have in our current administration to just put people away really fails to recognize how complex this decision-making process. I would love one follow-up sentence to, we need better mental health care. It's not a gun issue. Big one. Yeah. I do find also that there is a huge struggle going back to the injectable medications, that even among these very marginalized populations, the people who are the first to take advantage and trust the medical system and to trust what's in these injections are white folks. So I see anecdotally a huge disparity in terms of people trusting what's going to go into their body. And why wouldn't they, given historical prevalence, given the notion that these things are new and they're untested. And I've even seen one example of tardive dystonia which is like this advanced symptom that's a side effect of neuroleptic medications of an injection, where I had a client who just could not balance, had involuntary muscle movements, struggles just kind of walking, getting up, moving around the community. And again, how do you regain trust? How do you gain trust within a system if you're given kind of new medication that does that? But yeah, I think that we seek, from the eugenics point of view, we seek quick, easy solutions, and brushing people away in a way where we don't have to think about it really negates the complexity of the situation. I have one client example I think of a lot where, as a team, we would constantly discuss, is it humane to keep this person or allow him, quote unquote, to be in his own apartment? And this person was very isolative, had a very consistent schedule. Every day he would get on the bus, go to the mall, go to Cinnabon, of all places, and get out one coffee, come back on the bus, and then essentially watch DVDs, the same ones, over and over again. Did not have a social support system, generally looked like his mood was really low, didn't really get out. And one feature of it I always found interesting is that he really wanted us to get him a stockpile of 10 DVD players. So when the DVD format became obsolete, he would always have an extra DVD player because they weren't going to manufacture them. So the rest of my life, I need to make sure these work so I can do my routine. Is this person better off in a locked setting where he doesn't get the bus ride to get the coffee? He doesn't get the social interaction. He doesn't get to watch his movies. It's one of those everyday ethical situations that we talk about. So I think every single individual, on an individual basis, the ethics of it expand as you get to know them more. They don't become more minimized. No two people are alike.
Sure. Something that I was wondering, I heard Dr. Carroll, and I've heard many other people say, I don't trust big pharma. I don't trust the medical system to be getting vaccines. I don't want weird things going into my body. And what you were mentioning earlier, as far as medications and how many marginalized folks are less likely to trust the medical system, I'm wondering if there's any Venn diagram there, or if it's two separate circles as far as populations who are not trusting of medicine.
Yeah, I think it comes back to all or nothing thinking on this. This issue, I understand the impulse, given everything I've said about the impact of medications, where someone would be like, I want a holistic cure, a solution to this. And again, just going by anecdotes as well as what the research actually shows, when I've seen people, and I have seen this happen, where people's are optimally free from this previous suffering they had from symptoms of schizophrenia, for example. I've seen individuals say, I'm just going to go off my medications. And I've watched in real time that does not solve the problem. I've seen people go on very restrictive diets, go off their medications, not change anything else, and the symptoms resume just as much. The examples I've seen where people have really done, I'll admit in some cases better than I could imagine for them, are one case example I can think of is someone began with a routine, just volunteering, then got a job, then started training for a marathon, then started teaching. So you had all these components
Right.
that coincided with him reducing his medication. So it was basically a subtherapeutic dose, but there was still a little bit in there.
Sure.
And you had the routine, the exercise, the sense of purpose, the intentionality in the day-to-day life. I don't know which one of those you could take away, or several of them, to make this all work in combination. The one evidence base that is pretty much conclusive is that exercise, especially high intensity interval training, can really help alleviate and kind of heal those neural pathways as a starting point. I would imagine that a dietary change could contribute to it. I just really struggle with the idea that there's kind of a one and done solution to a complex.
You definitely put it together for me. The overlap there is holistic. Like folks, 1000%. The folks thinking, and I won't demean anybody's choices, but the ones who can like eat and exercise their way out for the Carols who can heal myself. You can laugh for 10 minutes a day. I don't know, whatever it was.
Yeah.
Regardless, right? Rather than getting something that they don't understand into their bodies, yes, can do these things. And then folks who really don't want to experience the side effects of medication, but do, holistic practices.
Yeah.
Which makes
sense. I would say that sounds great for you. I'm happy for you, but I would, again, as a thought experiment, just try to do that for a month, living in Section 8 housing with $300 to work with at the end of the month, SNAP benefits cut, no grocery store within 5-10 miles of you. Just give it a shot. See how that works. See what bandwidth you have left at the end of the day to integrate this lofty idea.
Yeah. And along with the reduced capacity to self-start is also something that I will see from folks in my practice who really want to do like a holistic change to whatever it is that involves diet, that involves exercise. And like we will go back and forth about them wanting to do these things. And I will work for years with people who want to do things holistically with absolutely no progress. And not that I have judged, but I will continue to meet with you to, work on these things, but there has been no path that has made doing any of these things easier. So now that you're saying that, that's interesting. Yeah.
And I'm not as familiar with the research as obviously you are, but thinking about that in terms of kind of the cart before the horse situation is this idea that if we just put people in these isolated situations on these farms, all their issues that they're dealing with in the community would be healed. It's like, do we have an evidence base for that? Do we have a comprehensive study that demonstrates that if people with vastly different presentations of the illness, and I often go back to this, it's like thinking about severe and persistent mental illness, like trying to think about it again in that thought experiment of trying to make it a kind of a spectrum. Like we all react to things, or we think we've heard something that's not there or seen something that's not there on some level. And I like to think about it as, whatever someone's experienced, genetics, trauma, your mind is trying to protect you and trying to insulate you from the horrors of the world or what you've experienced. So you might have one person who, like I said earlier, really enjoys living in that world they're in. I mean, I had a client who believed that he was not just the creator of this universe, but the universe prior to this one. And that there's like a secret language in the Bible that only he can see that's projected in the air that means that he will eventually ascend to his role as the God more powerful than the God in this world. And it is a completely consistent worldview that is within a world that no one else can relate to, but it's logically consistent. It has depth. It has sort of a story to it. People enjoy interacting with this person. He's not a threat to anyone, but it kind of impacts every situation that he comes in contact to on a day-to-day basis. up to and including hospitalization, because he thinks that going to the hospital is part of his persecution and his redemptive arc.
Oh.
So you take somebody and you think this person can be healed of this versus someone who is comprehensively suffering with persecutory delusions, voices that make them feel demeaned, hearing things that make them feel really uncomfortable on a day-to-day basis, literal pain in your body. If you are a victim of torture, you know, you feel it in your body, like not like literally, like in your stomach, in the places where you were hurt. How do you kind of codify a treatment for all these different individuals that is going to work, especially based on how little we understand of the mind in general and why someone would experience this?
This has been fascinating.
Yeah.
Kyle, thanks so much for coming on the show.
Thank you so much, Jessica. It was a pleasure.
Yes, this was definitely a section of my conversation with Dr. Carroll that I was least able or experienced in replying to. So I really appreciate it.
Yeah. Well, thank you for the opportunity to think through those thoughts in real time. I appreciate it as well.
Thanks so much to Kyle for coming back on the show. The day this episode is published, Casey Means is having her first hearing in DC as the presumptive Surgeon General. We'll be back with those updates next week. This has been Making It Awkward. I'm Jessica Wilson. You can find me on Instagram at jessicawilson.msrd. You can buy my book, It's Always Been Ours. You can join the Patreon and continue the support of the show. You can write a review, subscribe, follow the show. And until next time, friends, make it awkward. This has been edited by Jen Jacobs, who was one of the few people, it seems, who did not love Reagan and supported by the legacy of Sacramento Outboard Services.